My name's Tim Tyler, and this is my co-host Rob Shapiro. We have our executive producer Donis, and this is the Sports Medicine Research Rundown, where we talk about a pathology, the past, the present, and the future, and maybe the surgical or non-operative solution to that particular problem. Tonight, we're going to tackle all things meniscus, and especially the meniscal root, because we've been doing some research in this area, and I thought I'd bring an expert in to talk about the meniscal root and the meniscus. Nick, can you tell us a little bit about the meniscal anatomy and the medial versus the lateral versus where the roots are and the blood supply first?
Yeah, so they're very different medially and laterally, and a few quick points that relate to pathophysiology and then obviously addressing treatment. One is that the medial meniscus actually covers less of the tibial plateau compared to the lateral meniscus. And what's the clinical relevance? Subtotal lateral meniscectomy tends to be a bad actor because of the loss of more coverage than, say, medially. All other things being controlled for in terms of malalignment. Two is the medial meniscus is well fixed and with attachments to the capsule, and it has a certain amount of excursion. The menisci, we know from Freddie Fu's studies earlier on, definitely moves, particularly with rollback and flexion and with load bearing. So load back, say if you're doing squats, the meniscus moves, but the lateral meniscus moves more than the medial. So the medial is more tethered. And that gets into some stuff we'll talk about with centralization and with root repairs. Number three, the work, the landmark work done at HSS with Steve Arnowski and Russ Warren with India Inc. Shows that the meniscus has some areas that are less vascular and other areas that are more. And traditionally it was that, the peripheral third was very vascularized and the inner third was really almost avascular. But I will turn your attention to some brand new work that's been done on meniscal vascularization studies, state-of-the-art work by Jorge Chawla at Rush that he just presented at Northwell as our visiting professor, which shows that vascularity construct that we have talked about since the early 80s is actually not as accurate. And there's more vascularity than you would think, which I think is important to share with you relative to the fact that we continue to say you got to fix. And what is repairable and what is healable may be greater based on this updated vascular evidence.
Do we still go?
Yeah.
Do we still go with the red zone, the red white? And
well,
the white
it's easy.
Yeah,
so that the concept of repairs in what's called the red, which would be the peripheral third and the actual capsule, versus red white, which as you come more to the intersection, versus the inner margin, which is white, I think is great for communication and for some level of classification, but I would submit that in 2025, we need to think a little bit more about what's new, and perhaps there may need to be a little bit of an update. The other concept with vascularization is age. It changes with age. So we do know that, say, an adolescent or pediatric athlete versus, say, an older patient, which we will fix menisci in 50-year-olds if it's viable, that 50-year-old may have a different blood supply than a 14-year-old. So there's age. And the other thing in terms of anatomy, I think, is ultrastructure. We know a lot about ultrastructure. So different tears, whether they're radial, horizontal, or vertical longitudinal geometric tears, tear along various fiber failure lines. It's traumatic and shear or compression, but why do some people get a horizontal cleavage and why do some people get a bucket? And a lot of this gets into perhaps a more elegant understanding and recognition of ultrastructure. And if you think of ultrastructure as rebar in concrete, there and the rebar, which is your metal embedded in your concrete, the actual radial fibers, longitudinal fibers, and the random fibers that exist in the meniscus are very different in different patients. And that those fibers, they're collagen fibers, are the rebar, and sometimes failure occurs because of perhaps different orientation of that ultrastructure. So this is sort of, I guess, in brief and summation, what I think is important to think about relevant to anatomy and pathophysiology.
Based on the location of the tear, you'll choose to fix it or not. And based on the type of tear, what types of tears will you not fix? And in what region kind of?
Yeah, I like to say that if I had to, I don't like to list one thing. I think it's multifactorial. But if
Yes.
I had to say to you, what is the single most important factor in repairing, it would be tissue viability. Now, what does that mean? Degenerative tissue, if you think about it, is frayed fabric.
Hmm.
And if you take a frayed fabric shirt to a tailor, the ability to sew it might be different than a linear laceration in, say, leather that is not frayed. So I think tissue viability is one of the things that drives what we're going to do. Of course, compliance with rehabilitation, compliance with a longer recovery, technical, and then some of the things that I think, Tim, you're citing, which is geometry. In terms of healability, there are at-risk repairs and perhaps, I never call it slam dunk, but repairs that are more predictably going to heal, which have to do with zones. And you talked about the red
Hmm.
versus red white versus white white. There's no question that there are some differences in chronicity, that if you have an acute bucket versus somebody that comes in that bucketed 6 months ago and displaced the bucket into the notch, so they're not really locked and they're running around with some pain, deformity may set in, and that deformity and deformation may change the outcome of the repair, and that
Right.
changes your decision. So I think the important thing, I think, in terms of the takeaway is tissue viability, patient compliance, and geometry. But nonetheless, I think we tend to, at least I do, and we have these conversations with patients every day, tend to be more proponents of repair, particularly what sharpens your pencil, particularly if you're going to do the ACL,
Sure.
right, versus an isolated repair.
Um, can you tell tissue viability off of an MRI, or is that not possible?
That's a fantastic question, and I will tell you, not really. We're
No.
just not that great with that. Tissue viability can be analyzed on an MRI based on, say, if you have an older patient, or if that patient has some osteoarthritis. So you're now thinking, okay, this looks more like a degenerative knee.
Hmm.
I think it's also in a patient that might have certain patterns of horizontal cleavage that maybe in an older patient, you can say there's fiber failure. I think that if you have a complex stellate and really a complicated geometric pattern that kind of looks significantly ripped up, you usually can say, I think even in the best of hands, I might not be able to repair it. So I think, but the answer to you directly is we just aren't that great at it yet. And
Okay.
some of the repairs are opportunistic, which means you have to counsel, the patient has to be prepared, the patient has to accept in a shared decision-making model and be ready for a longer recovery or a different type of rehab. And then you have to be ready with your team in the operating room to have your toolbox open and available to be able to do a repair as well. So I think those are some of the factors that go into the overall decision of going to point A versus point B.
I might be jumping the gun here though, but are you still repairing? When I went to the conferences back in the day, they were using meniscal arrows. They were using inside out, outside in suture techniques. What are they using these days to repair the meniscus?
Yeah, so the current, and it's changed. I mean, the arrows that dates you, Tim, the
Right.
arrows
I know.
came out. I was on the Bionics board, and that was
Yeah.
94. So it was mid 90s. It caused an explosion in increased repairs. Why? Because orthopedists are like everyone else. If it's easy, they do more. If it's harder, they do less. And the point is, the arrows made it easier. The various iterations and sort of the cycles of different widgets, which just tells you there's so many because everyone if it works for you, it works, and there's many ways to skin a cat. But I would answer that the state of the art in 2025 is to use suture,
Suture.
vertical mattress configuration,
Mm-hmm.
And that suture could be inside out as well as all inside. And to just have, it's like closing any tissue, having a meticulous construct that's strong and that is well done. I think though it's current all inside in 2025. You'll hear at the meetings the gold standard is inside out, and I would debate that. I wouldn't argue it, but I would debate that. I think, and that has to do with the fact that the caliber and bore of the suture is very small, and so it produces less of a hole. But I think that there are some really, really sophisticated current all inside suture devices that make the repair. It's never easy, but just I think more applicable to more surgeons.
Mm-hmm. When I'm thinking about the types of tears, when I have a patient with a bucket handle meniscus tear where they can't flex their knee, that's kind of a surgical emergency in my mind. Would you agree with that?
Yeah, I think it's so that when I mentioned the bucket before that gets displaced into the notch, they'll come in and they won't have full locking, and they may not be treated as an emergency, and they may come in at a later date. But the person that comes into your office limping and with loss of extension or inability, maybe locked between
Mm-hmm.
40 and 70 degrees, if they sometimes will unlock within a few days if you put them on crutches, but and I don't think it's an emergency where you have to go that night, but I think
Right,
you need to
right.
do that. You should do that, within 7 to 10 days, and due to the issues that I think occur with perhaps propagation of the tear or deformation when they're walking on it. So I think it's an urgent.
And now with the literature and knowing that meniscal root tears really lead to osteoarthritis, maybe that's a more of a urgency to repair it than to treat it non-operatively. And we'll talk about the non-op results in a second, but that could be another situation where we need to get on this right away and repair that.
Yeah, the thing about root tears, and I like to share with patients different analogies for communication. I say, look, uh, meniscal tears, like when you walk into your house and you have a throw rug or an area rug, and when you first catch your foot walking in the door, you catch the edge of the inner fragment or inner margin, and that is where you flip the rug up and it tears. That's a classic meniscus tear. But a root tear is where, if you have floor to floor carpet, if you ever see the carpet installers, they tack the perimeter. And so now that rug or that carpet is essentially anchored at the perimeter of the room with those nails. A root tear is where the entire perimeter of the rug or carpet has been avulsed. That changes the biomechanics of the knee, clearly. We know that from the
Mm-hmm.
literature. And what it does in subsets, it can result in extrusion, where now the kinematics are affected versus the entire meniscus. So in some ways, people will say a root tear can contribute to with essentially dissociation of the attachment, can really behave biomechanically like a subtotal or a complete meniscectomy. So it can be, not always, we're going to get into the differences, it can be at least the beginning of the end of the knee.
Yes. In preparing for this podcast earlier this week, I read that younger people get root tears also. They're acute, and older folks have more of a chronic root tear. But what are the primary signs and symptoms of a root tear? I mean, I read pain on deep knee flexion. However, if a patient has a meniscus tear, a horizontal cleavage tear, they're going to have pain on deep knee flexion, correct? What are your
Yeah, yeah.
hallmark signs?
Well, I think you're really bringing up a very important point. If you read the literature, and there's been about 2,400 articles just in the last 5 years on root, it's really a hot topic, and at the meetings. And the takeaway should be that there's a bimodal distribution of meniscal root pathology. What does that mean? So this is in general, but it's an easy way to communicate and learn this. In
Mm-hmm.
general, younger patients with acute trauma, with an ACL, tend to have avulsions and root tears of the lateral meniscus. The average age in that group, if you look at the literature and you read the articles, is around 25. Different animal, apples and oranges, right? On the second spike on the bimodal, That tends to be medial. It tends to be more degenerative, tends to be older patients, average age between 55 and 57, tend to have early degenerative changes, as I said. And there is a higher predominance in female gender and higher BMI. Apples and oranges. Now,
Mm-hmm.
from the standpoint of your question of etiology, that latter group, the older group,
Mm-hmm.
medial, don't always have a lot of trauma. They don't have a significant ACL. They don't have a pivot injury. They may have a pop. They don't always, but they just sort of develop, acute onset of pain. Their symptoms tend to be more posteriorly referred or posteromedial or sort of a dull ache over the entire knee. The former group, younger, the bimodal spike, younger,
Mm-hmm.
ACL associated, lateral, they have an acute injury and it's within the context of a larger problem. So a lot of the patients in the second group that we see will say, it's almost like an arthritis type symptom. They'll say, I have an ache in my knee. They don't have mechanical symptoms like the younger patients. Certainly, they don't have locking. So I think it's very, very, very important if you are going to treat root tears, and certainly for those therapists on the call, you need to know and say, okay, and it's not just simple profiling, but just understand which version of the root is, and they're not all the same.
Yes. And are there special tests that you like to use for diagnosing root tears or meniscus tears? I mean, for root tears, possibly palpation of that meniscal excursion you talked about, or McMurray's or Apple's compression. What is your go-to test for someone with a meniscus tear and possible root tear?
Yeah, I think it's less sensitive and specific in terms of positive predictive value
Mm-hmm.
of the test. So I would tell you I don't have one favorite. I examine everybody thoroughly in terms of joint line tenderness, range of motion, pain at terminal flexion, pain with axial compression, various types of compression, axial testing such as Apley compression. But I'm going to answer your question. I like what's called a Childress test, which is essentially,
Oh, I don't know what that is.
okay, so what it is,
Yeah.
I don't like to use names. I'll just call it a flexion overload test rather
Okay.
than use somebody's name. I say squat down on your heels, like we call that a duck walk or a marine walk for people, and walk in terminal flexion. And again, this is not sensitive and specific, and it's not an aha, oh my God, that's a sine qua non pathognomonic for a root tear, but they just seem to have more pain at terminal flexion in compression. So when they sit on their heels and you ask them to walk. And so that's one test.
I used it also. I didn't know it was called that. I
Yeah.
call it the walk like a duck test.
Yeah, walk like a duck. Because it's axial compression. You
Yeah,
get to roll
totally.
back. The femur rolls back in flexion, right? We all know that.
Yeah,
And so what are you doing? You're crimping the posterior horn. And that's the root.
totally. I have been fooled by patellofemoral pain in those
Yep.
in those
That's why
patients.
it's not
So
sensitive and
right.
specific.
Um, do you get an X-ray or
Everyone gets an X-ray.
is it useful? What do you for meniscus?
Yeah. You
Yeah.
get the X-rays because some people say, "Why are you getting the X-ray? I have the MRI," or "Just get the MRI, don't get the X-ray." Bad. You got to get the X-ray because number one, you want to make sure there's nothing weird going on, which there
Hmm.
usually isn't. So they sometimes say, "Why are you getting it?" I said, "These are the reasons." Number two, you want to assess their joint space in terms of narrowing. So I get a 45-degree PA, which is a Rosenberg view, as part with an AP and a lateral. And really what you're looking for is not just joint space narrowing, but early degenerative change. Now,
Okay.
maybe less relevant in that 22-year-old ACL lateral root, but the 55-year-old, you want to understand, do they have some early radiographic signs of breakdown of the joint? Now, always remember that breakdown of the joint occurs first, and then second, you see it arthroscopically,
Yeah.
and third, you see it on X-ray, and then of course with MRI, we'll pick this up. But realize that we're not treating X-rays, but it's again the composite and the sort of contribution to your gestalt diagnostically that I think you should check it. And if you do see some arthritis, you have to at least be aware of it. Plain
The,
film. Yeah, plain film.
the MRI would be the gold standard, though. It's
Yeah, the MRI is very good. I mean, the one thing I will say is it's gotten so much better, and they really do pick it up. And it's called the Terry Thomas sign, which is where you see a gap, like a gap in the tooth. Like the older people might remember Terry Thomas, who was an actor. But what happens is the meniscus, as you follow it across on your transcoronals, you'll actually see it ends and is like a gap. And that's where the avulsion is at the root. And it'll pick that up. You could also see it on transaxials. The MRI is good. We tell all clinicians that they should obviously read the report, but look at the MRI themselves. Now, it isn't 100% though. And you may sometimes, but it's pretty good, but you may sometimes see it and then have to be thorough in your arthroscopic assessment and always check. We teach and we profess that you have to check the root attachment in case the MRI missed it and now you're in the knee scoping the knee and now you don't want to miss it. So I think that's very important.
If you have an athlete that you're taking care of and they've had a previous meniscal repair or meniscectomy and they hurt their knee, they have these signs and symptoms, is another MRI specific, or does the usefulness of the MRI fall off in somebody that's had surgery on a meniscectomy already the same
Yeah,
knee?
that you're spot on. The MRI, and we see this a lot. The MRI, the usefulness falls off because frequently they'll say, and this is classic, we kind of joke about it. The report will say, that's why you have to read it yourself. The report will say, abnormality in the meniscus. This may be consistent with prior meniscal surgery or resection because they're not sure if they don't have the history that you have versus a new tear. And then this is the sort of the thing they'll say, clinical correlation suggested, which really is code for, we're just going to throw it back to you as the clinician with your history, your physical exam advantages to make it. But again, don't treat the MRI. If you have a root tear or anything, or a terribly arthritic knee, and the MRI looks crappy and the plain x-rays look crappy and the patient comes in and they're not so bad, that's a good thing, and treat the patient. You can have other people who are dying and their x-rays don't show a lot of arthritis, or maybe the meniscal injury doesn't look terrible, but I think you treat the patient. So always the integration of your objective imaging has to, I think be taken into consideration with your clinical evaluation.
I presume you'll send these patients to physical therapy for non-op treatment first. Is there any meniscal patient besides that locked bucklet handle that you'll say, hey, let's go to the OR right now? We got to do this.
Yeah, so no, and that's maybe the historical perspective I could share with everybody when we talked about 36 years in practice. That was, I came out, I'm very involved with the Arthroscopy Association, was teaching arthroscopy, meniscal works back starting in 88. But I will share that there's been a trend, and this is support. I'm not making this up. This is supported in the literature. There's several publications in the last few years that have showed a decrease in meniscal resection surgery, which has to do with, to be perfectly candid, a little bit of reimbursement. But it is also, I think, clinical standards have improved where people say, listen, 60% of people over the age 60 who are asymptomatic volunteers will have a meniscal tear on MRI. And you better not operate on them. Right. In addition, an even greater number of people who have some early degenerative changes in that older group, they don't have clinically significant MRI, and they'll come in with the MRI and they go, look, I have a tear. I go, no, you have arthritis. No, I have a tear. I said, no, that's not a tear like ESPN. You're not 18. You're not a tight end. That is a common finding in association with the arthritis. They go, what does that mean? I say, your pain generator is your arthritis. I'm not sure it's the meniscus. They go, well, what does that mean? I say, we tend to not operate initially. So that brings me back to your question. So my initial treatment algorithm in a patient who is not dying or locked, as you said, but does have an MRI positive meniscal tear with some arthritis and wear and tear, or even if they don't have arthritis, is basically to say a few things. Go on an anti-inflammatory agent, ice it, let's watch it, put everybody, I mean, not to say everybody, everything, put just about all of them in therapy, riding a bike if they don't want to go to therapy. I might not inject them on the first go round, but I'll say, come back and see me in a month. If they're still having a problem, then step 2 in my algorithm is to inject them with
With what?
with a,
PRP?
no, I use a corticosteroid.
Cortisone?
Yeah, very practical. Corticosteroid first. Now, some people will say, I want PRP, and
Uh-huh.
another conversation, and we deliver that. We do PRP. I won't go with gel initially, but I think the standard for me is a corticosteroid at that second junction in the touch. And I can't tell you how many of them get better. And particularly the roots, because you think I operate on every single root. And then they come back 6 weeks later, they're still having a problem. We're now approaching 12 weeks, and that's your magic number where you say, well, maybe we need to talk about doing it, and we didn't lose the window of opportunity relative to time. But I think that I do want to say and emphasize, and I know I'm conservative, I'm admittedly conservative with
You
it,
are.
that my first choice is in this group is to give PT. Now, you and I know the literature. I can tell you about physical therapy crossover and all of the studies
Yes.
gone and shown in randomized controlled trials that PT, not blinded, head to head with some meniscal surgery may not show that much of a difference, although there's a 30% crossover rate.
Right.
So, but that is some of the stuff that has taught many of us to be a little bit more conservative and thoughtful and not jump the gun on every meniscus tear and take them to the operating room in the first few weeks.
Yes, but to be honest, as a physical therapist, I have to be honest and say that, you know what? The literature shows that we do very well and the patients do very well at 6 months, but they go on to decline after that. And then it does not halt the progression of osteoarthritis,
Well,
unfortunately.
because it's osteoarthritis, not a pure meniscus tear.
Right.
But I will tell you, and I learned this from I used to lecture up in Ottawa from my Canadian colleagues, and this is always eye-opening. I'd go up there, we'd present cases to each other, and they would say, that patient, to get that patient on my schedule with the province budget and the delays because of the Canadian health system, will take anywhere from 12 to 18 months. And if you just put them in physio and they have to wait 12 to 18 months, the number of patients who then do not need surgery is low. Now, I know what you're saying. What's different is chondroprotection and sort of the natural history of a degenerative joint.
Yes.
I think to that point that that's genetically predetermined. That
Mm,
there's some people are going to go gray, some people are going to lose their hair, some people are going to get a degenerative knee. Maybe the rate of progression is not clear, but I don't know. I think the meniscus is happens to be in the wrong place at the wrong time. Now, again, very different from the 18-year-old lacrosse player, blah, blah, blah. We're talking about, again, bimodal or different types of distribution of pathology.
right. Um, when you have a patient that has evidence of a root tear on MRI, what are your key factors in decision making, whether it's a medial or lateral meniscus or anterior or posterior root? What is your algorithm there?
Yeah, so all of the above. The anterior root is very, very uncommon. It doesn't see the load and compression that the posterior roots. So we're really talking posterior roots.
Okay.
I actually just operated on a lady. I did a lateral root on her. I did that after 6 months. I actually just, it's anecdotal. I just saw her back literally yesterday, Tuesday, and she's about 6 weeks. She's 7 weeks out, off crutches, and so far doing great, walking on it. She has a degenerative knee. She's in her late 50s and she's lateral. On the medials, I will perhaps be a little more conservative to start because I see more degenerative change in that group. And so, what do I look at? What are some of the clinical things? I look at BMI. I look at as it relates not only to load, but then I think, okay, if I do a root, the rehab right now is limited weight bearing for 6 weeks. And is this somebody who has good upper body strength relative to their BMI that perhaps puts them in a wheelchair for 6 weeks? And I think that's called the crutch test, which is if they're not able to handle crutches, maybe we don't want to, we're not discriminating, but we don't want to be as aggressive operating on that group.
Sure.
Okay, I look at degenerative change. I look at extrusion. I look at how they've responded to initial non-operative treatment. I look at what their goals are. I look at, the level of symptoms. If they really have an inflamed knee and they really have restricted range of motion, but without locking, all of these factors go in. And then I present this to them. And I think, in a shared decision-making model, what the patient thinks about it, because if somebody says, I'll give you an example, said, no way in hell am I ever having surgery, I'm going to have different conversations with that patient who might be versus the patient who says, listen, I've gone on the internet, I understand the natural history of root, and I understand, that the conversation and details might not be linear, but if I'm a candidate, I really want to fix it. That's somebody I'm going to have a different conversation. So all of these things,
Hmm.
fall, as you know, Tim, into the art of medicine.
Yes. Which technique do you use? The transtibial pullout or the suture anchor technique when you go and repair a root?
So I used transtibial for about, oh gosh, probably about 7 years. And just
Okay.
last year, we switched to, I'm not here to mention proprietary names, but
No.
there's a proprietary aperture suture anchor, which is basically all soft suture, no
Hmm.
metal buttons, tensionable, and the fixation pulls the meniscus root down right
Down.
at the anchor. So it functions, and it's kind of easy to do. It functions as a suture anchor at the level of the anatomic reattachment site versus the bungee cord on a transtibial pullout where you have to,
Right.
basically transcend 7 centimeters of bone tunnel and put an anchor down there. So we
Right.
think, actually started 2 years ago and we started last year. I think this is a major advance. This is highly technical stuff, but the people who do this work are excited about aperture fixation.
I actually saw some outcome studies that are listed on the program down in Nashville, so in at the AOSSN this year. So I'll be
Yeah, yeah,
anxious
yeah, yeah.
to see their
Yeah, it's hot.
results.
It's a very hot topic. Yeah.
Yeah. Um, so I wanted to go into the research article now. Unless Rob, do you have any questions right now before we tackle the research article? Or
I do. So what did
uh,
it tell us about the idea of like hoop stress? And what does that mean? And how can you measure it like the pressure wise or the ability to maintain that?
Yeah, you can measure it in the lab, but you really can't measure it clinically. I mean, in situ and in vivo. I guess you could, perhaps, but I don't know of that's more of a lab study. And what that just means is that there's a natural, due to the circumferential band, again, those fibers I was talking about, that architecture, microarchitecture, the circumferential band, think of it like a bale of hay. If you think about the hay, and you just have a blob of hay, it's going to go all different ways. It just basically there's and it's dispersal in different directions, vectors. Now, if you sat on a bale of hay and compression, and it was just loose hay, it's going to extrude and go in different directions as well in a sort of chaotic series of vectors. If you essentially wrap the hay into a bale, whether it be with rope or strap or just a covering around it, now you sit on the hay, it is essentially resisting the hoop stress. Another example is the barrel. That's where they get the hoop. If you think about a barrel that's made out of shaped wood, curved wood, why doesn't it just collapse when you sit on it? Why is it so strong? Because it has essentially the circumferential binder on it. That's what the circumferential band of the meniscus has. And when you lose that, either through perforation, resection, or tearing, or dissociation due to a root, the ability to resist hoop stress that comes with compression and loading of the knee is lost. That's the whole concept. It's very
Okay. And
important
one more,
mechanically. Yeah.
then one more quick. So your ACL comes in, they have a lateral root. Do you mix them both together, or are they two separate procedures, or
Two separate
how does one affect the
procedures.
other?
Yeah, but
Separate.
we're super aggressive on those because those are the kids, and you're doing the ACL. You're there for the ACL, so you better fix that root. And so that's a gimme. Two separate
So you wouldn't do
procedures.
them. They come in twice. How
No,
far
no, no. I
apart?
do.
Or one procedure,
That's
one
correct. I do it
surgery.
all at the
Okay.
same time. Yes.
Okay.
Good. I chose this article because it was just a case study with a meniscal root repair, and I've seen a couple of them recently. So I just wanted to go over it and have you comment on it. It was a 45-year-old man who had a complete tear of the medial meniscus root attachment, 3 millimeters of exclusion. Um, are you sending that for non-operative therapy, you think, or are you going to try non-op on that? What's the consensus out there?
Yeah, so I thought this was a good article. This is the
Yeah.
Newcomb article from University of New Mexico, Albuquerque.
Mm-hmm.
And if you think that root tear stuff is cool to talk about and somewhat, interesting and hot, meniscal centralization is even hotter. So what that means is if think about my rug analogy, right?
Yeah.
The carpet is pulled out from the wall. You're the carpet installer. You're going to fix it at the perimeter with the
Right.
tacks. That's your root repair. And then in the middle of the room, you're going to put a few more tacks strategically to have the whole thing tacked down to the floor, and it's not going to balloon out. That's the concept of centralization. Now, the reason that has come up is due to extrusion. We know that if you repair a root that is extruded more than 3 millimeters, it's already kind of being squished out, that number one, that extruded residua might end up with a poor result. But even more importantly, and this came from Aaron Critch in the Mayo group, what's the cart and what's the horse? So what we will tell you is what happens first. Did the root avulse and separate from the root attachment and then the meniscus extruded? Or did the meniscus extrude due to the meniscotibial ligament insufficiency and then it pulled the root out? And we don't know because this is so hot and so new. But Aaron Critch, a good friend of mine at Mayo, who has
Yep.
published a lot, thinks that the extrusion occurs first. I'm not sure, but I'm just telling you, I think it's kind of cool to think about. And so if the extrusion occurs first and you go in and fix the root and don't fix the extrusion, you might be cutting short your treatment. So that's where centralization comes in. And that's what this article talks about. Now, your question. So it's a 45-year-old. So it's perfectly in between I would say a younger patient compared to that maybe bimodal group. They don't talk
Mm-hmm.
about BMI, but it's a younger patient and he was playing tennis. So we think this is perhaps a more athletic person who is at that age versus, say, a 58-year-old with a degenerative knee who has a high BMI. So to answer your question, I would be more aggressive. But realize this is a medial tear, though. This is not a lateral. So I think it's kind of in between. It may have some degenerative components, but I think you would probably be more aggressive in fixing this earlier.
And they did fix it. And
Yeah, they did fix it, and they kind of talk about their technique and their
yeah.
rehab. And this is an open technique. So you were asking about arthroscopic repair,
Okay.
and I like that. And actually, George Paletta, if you know George from
Yeah, I know
HSS,
George
and now he's
Fleta.
in St.
Absolutely.
Louis, takes care of the Cardinals.
Yeah.
George published on open meniscotibial repairs, where you go just anterior and posterior to the MCL, make a little incision, fix the perimeter, stabilize it, essentially neutralize the extrusion, and do that arthroscopically in terms of the root repair. So it's an arthroscopic assisted. I think it's brilliant. And that's what these guys talked about. So I kind of like it. And I think
Good.
it is certainly pretty hot stuff.
So we'll spend the last bit of time and we'll talk about the rehab. Okay.
Yep. Yeah.
In this article, they made their patient toe touch weight bearing for 6 weeks, and they limited motion from 0 to 90 degrees in a hinge brace. And then they started with a little bit more aggressive physical therapy at 2 weeks. My question for you is are you still non-weight bearing with your patients for 6 weeks after meniscal root repair? And
Yeah. So two things. In general, yes, that's what we've been doing, strict non-weight bearing. And I know this, maybe some of the people on this call will smirk, but I'm not trying to be flippant about this, but I find that when I tell people non-weight bearing, it equates in a subgroup of these non-compliant patients to toe touch. If I tell them toe touch, they're really partial. And so
right.
I tend to go non, and then I bet they're going to be limited. Now, if the world is perfect and it is a perfect patient and there's 102% compliance, I'm fine with limited weight bearing. And then the second part to that answer is, and I've had this discussion with Aaron Critch, is that with some of the new aperture techniques, with a centralization, with better anchors and really state-of-the-art suturing techniques, it's probably stronger than you think, and we're probably okay. The problem with this is we don't have a lot of long-term data on these outcomes, so the rehab is still sort of a little bit behind.
It's
And
involving.
it's still kind of what I'm talking about is still not truly evidence-based, and that's why it's a little bit all over the place. We don't have long-term. And what you probably would need, like some of the work done at Ohio State with David Flanagan's group and Josh Everhart, where they really did randomized trials to show with certain meniscus repairs, we can weight bear earlier. Second part is range of motion. I do like the 0 to 90, and I agree with that, because as you go beyond 90 with that roll back we talked about, you're getting compression and you're getting a bit of shear at the level of the root and at the level of the meniscotibial, is at least in this case, open repair. So I usually go 0 to 90 for the first 6 weeks. Then they come back, I go 0 to 120, and I still use traditional meniscus repair methodologies, which is, I just wrote a prescription yesterday, Tuesday, for somebody who says, listen, avoid flexion overload, particularly terminal leg press, squats, lunges for 3 to 4 months from the date of surgery, so that you're really not overly stressing in terminal flexion with load. So I think
Okay.
that's sort of the second half of that rehabilitation.
Yeah, knowing that shear is the enemy, Nick. When are you going to let them cut and pivot and do that? I mean, are they going to get? Is it a year before they get back to sports, playing sports?
Yeah, I always preface, and I do this on the panels when I'm with all my friends and we get asked these questions from the meetings. I say, look, I tend to be a bit more traditional and a bit more conservative, admittedly. And when my friends say 3 to 6 months back to sports, I tend to say 6 months. Because patients, when you say 3 to 6 months, what is human nature? They hear 3. So I just say 6 and on return to sport. And then what I'm really interested, Tim, is, and we just did a panel, you talked about Saturday, I did a panel on performance testing and batteries of tests on ACL. And now what we're interested in is what's your array of and battery of tests for getting people back after meniscal surgery. And there are things with squats and certain things with not just hop tests, but hop tests and flexion that we can do to be a little more scientific and objective with telling them, okay, I'm going to release you. But I think I tell them, by and large, and this may sound cookbook-ish, I tell them 6 months before they get back to pivot and cutting. But the cookbook is not only time dependency, it's going to be functional performance assessment metric dependency.
Excellent. Rob, any other questions from the audience or others?
We had a couple of questions, I think, in the chat. I think you answered one. One was from Rob Penrose. Dr. Sgaglione, do you use any biologics in conjunction with his meniscal root repairs?
So I use I have been for my entire career, due to my connections to Dr. Arnowski. I've been and have, we've written about it, we've lectured. I use biologics in all cases of isolated tears. In my tears that are ACL associated, the tunnel gives me my biologics, so I don't have to do that. In isolateds, I will microfracture the notch for blood, or I will use some fibrin clot, which is just not PRP, but just fibrin clot that I get at the time of the surgery, autogenous. On the roots, I tend not to, and the reason is I'm drilling, and there's blood that seeps up from the tunnel, and so therefore that is inherently biologic, but I'm not adding anything specific on an isolated root like I will, but it's nothing to microfracture the notch and get some hemarthrosis.
Somebody else, Seth, wrote, keeping in mind the anatomical differences between the medial and lateral menisci, do you think it would ever make a sense to centralize lateral meniscus root tears?
Great question, Seth. And let me tell you something. Go back to the literature. I think his name was Koga. The first the first meniscal centralization was done laterally, and then it was and published, I think, oh gosh, around 2006 or so. It's from the Japanese group out of Tokyo, Koga. So the first one was a lateral, and then it kind of centralization moved more towards the medials. Now, it's interesting because you would think counterintuitively, with all the excursion that the lateral side sees, and the fact that the lateral meniscal junction, the lateral meniscal capsular junction is less fixed than the medial, that it's sort of non-anatomic to centralize it because it moves so much. And that's my inherent bias about that it's sort of maybe a little counterintuitive. But there are people who do that centralization laterally. I would think about it a little bit more, but I do think it's a great question, and this is the kind of stuff that we debate. I will tell you, and I just want to say this in regard to that question, this stuff is so cool or so hot and new that everybody has an opinion, but I don't think we can say absolutely, definitively, blah, 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 both in terms of the array of anchors, where to put them, perfect indications, technique, rehab, and it's still, that's why I love that Tim picked this, because this is sort of innovation at its best. But whenever you talk about innovation and get excited about it, the good clinician always has a wary eye, and meaning show me.
I think that's all I have. I think there's nothing else in the chat.
All right. If that's all, Nick, thanks for joining us tonight. Really appreciate it. And thank you, everybody, for who's on the call tonight.
I really appreciate the invitation. And thank you very much for connecting. And have a great night. Thank you.
You too. Bye-bye.
Thank you.